Good afternoon, everyone. Well, kind of. It's 11 o'clock here in the East Coast. It's my great pleasure to introduce Dr. Hilary Highfield, MD, PhD, who is giving the talk today. She is a neuropathologist and ophthalmic pathologist in Louisville, Kentucky. She earned her MD, PhD degrees and did her AANP training at Vanderbilt University School of Medicine. Dr. Highfield joined the Vanderbilt pathology faculty in 2010, serving as an assistant professor in the Department of Pathology and Ophthalmology. She joined the Norton Neuroscience Institute in 2016 as a neuropathologist and the University of Louisville School of Medicine Department of Ophthalmology as an assistant professor gratis in 2020. She has served on the AAO Pathology Atlas Committee since 2014 and the AANP website committee since 2014, where she has been active in the AANP social media posting efforts. Dr. Highfield started her college years as an art major at Washington University in St. Louis, and she utilizes her visual training to create illustrations for ophthalmic pathology teaching. Without further ado, here is Dr. Hilary Highfield and her presentation on eye pathology.
Good morning, everyone. Well, we're almost to the afternoon, as Dr. Kenyon said, and I'm really excited to share with you today this basic eye pathology. We're going to look at the cornea, the conjunctiva, and the eyelid, and give a real basic overview to familiarize mostly fellows with this material. And I put my artwork in there, which some of you see on the social media sites that the AANP does, as well as some of the AAO sites for social media as well, the American Association of Ophthalmology. So here we go. I have nothing to disclose. So we're going to look at the key pathologic features in the differential diagnosis for corneal lesions, conjunctival lesions, and select eyelid lesions. Okay, and no photography, please. Okay, so we'll start with the cornea. And so I like to think of this as like a layer cake. And so most of the cornea is composed of stroma, but you have on the surface of the eye the corneal epithelium, which has a basement membrane layer. And then underneath you have the acellular Bowman's layer that once injured does not regrow. And the majority of the cornea is this stromal material, probably 90% of the thickness. And it's anhydrous, where you have very little water within that layer, which allows for the optical clarity of the cornea. So it's keratocytes with these collagen lamellae that are carefully laid for that optic clarity. Below that is Descemet's membrane, a true basement membrane that has high tensile strength, and then the endothelial layer, which are derived from neural crest cells. And so you'll see on the right here an example of some of the artwork that you'll see throughout. And then I use some of these images from Ralph Eagle's book. I'll show his book at the end as a reference. I think for learning fellows, this is an excellent book to use to learn eye pathology from the beginning. So here we are looking at the epithelium. So this is between 5 to 7 layers thick, and you have the basement membrane cells, which can divide. So you can see mitosis in that basement layer. On top of that, you have almost a cup-like structure where the wing cells overlay the basement cells. And then as you go towards the surface, the cells thin out and you have this non-keratinizing layer of epithelium with the superficial cells shedding off the surface. Below that, you have this acellular Bowman's layer. And if you did a PAS on here, you would see that there is an epithelial basement membrane layer here, which is separate from this acellular Bowman's layer. And then beneath that is the stroma. And so thinking about the epithelium again, it's stratified squamous non-keratinizing epithelium between 5 to 7 layers thick with that basal layer that can be mitotically active, the wing cells that fit rounded over the top, and then they flatten as they reach the surface. And then those basal layers are connected to Bowman's layer by an anchoring complex, and the cells are connected by desmosomes. So Bowman's layer beneath, you have that PAS positive epithelial basement membrane layer, and then you have Bowman's layer, which is this pink pale layer underneath. And so that's acellular collagen. It's about 10 nanometers thick. And the thing that's neat is once destroyed, it's never replaced. So the cornea really tells a story. So if you have a penetrating keratoplasty and Bowman's layer is missing, there's been some sort of trauma there, surgical. It could be an ulcer that was formed, like herpetic keratitis. The epithelium will regrow, but Bowman's layer will not. And you'll often miss some of the stroma in that area. So you know that there's been prior injury to that cornea. And so then the stromal layer, as we discussed, is most of the thickness of the cornea. So it's about 500 millimeters thick. And then the spindled keratocytes have those long branching interconnected processes, and that uniform spacing develops that optic clarity. The ground substance that's within there is mucoprotein and glycoproteins, and it coats each one of those fibrils, which brings us down to Descemet's membrane. So this membrane has high tensile strength that's highly PAS positive, and underneath it are the attached endothelial cells. So it's thin, it's elastic, high tensile strength. It contains proteoglycans and glycoproteins. This basement membrane is elaborated by the endothelial cells, which will be important as we talk about Fuchs dystrophy. And so it's composed of type 4 collagen, and it's strongly PAS positive. So now thinking about those neural crest-derived cells, they're a monolayer, they're flat and cuboidal. We lose them as we age, and they really maintain their corneal clarity. They both have ATPase pumps, which actively remove the aqueous. And as I stated before, the cell population declines with age. So now we're going to talk about corneal infections. So if you think about what protects the cornea, it's the epithelial layer, and then the mucous strands of the conjunctival epithelium. They can ensnare microorganisms to protect you. And then your tears, of course, have enzymes and antibodies that protect you from pathogens. So how does the cornea get infected? Well, a lot of it is inoculation by a foreign body. So you'll hear a lot of stories where people are working on their yard and working with their without glasses on, with leaves, and gardeners especially will get inoculated by foreign material. You can have an injury with epithelial abrasion, and then of course invasive organisms. Everyone knows about Neisseria. So one of the things I would like to point out early on is that a lot of the pathology that you do, you really need a good relationship with your clinicians. So I really would like to have a clinical H&P, describing what happened, whether the person had an injury, whether they're a gardener, et cetera. So I really do have a relationship with my clinicians where I get that clinical information and I'm able to contact them and ask questions to make sure that I know what they've been exposed to, et cetera. Okay, so here's an example of an injury to the cornea, where you can see here that there has been an abrasion. Okay, so if you look closer, this is a really low power view. You can see that it doesn't even really look like a cornea. You can't see the layers very well. There's very hypercellular, a lot of blue, so probably inflammatory cells. And then if you look closer, you can see that there are neutrophils that are within there, and you've lost the entire epithelial layer as well as Bowman's layer. So there's been an ulceration here. And then Descemet's membrane is below. So looking even closer, this is full of neutrophils, so this definitely is an infectious process. And the PAS shows you Descemet's membrane down here. And so looking for organisms, the Gram stain on this showed little small rod-like organisms. And so normally, just like anything else infectious, I do a Gram stain, I do AFB when I think it's necessary, I do a GMS, and then HSV1/2 immunohistochemistry if I think it's possible that it's herpetic. And with neutrophils, I do think about that. And again, the history is very important in that setting. And so looking at this is acute bacterial keratitis. Let me make sure I didn't skip a slide there. And so you have these neutrophils that collect in between the clefts of the stromal lamellae, and they release their digestive enzymes. And so not only do you possibly have an abrasion, but you also have this enzymatic digestion of the cornea by the neutrophil material. Okay. And so this turned out to be Pseudomonas. Pseudomonas has enzymes that destroy the cornea rapidly, so it will be a rapid infection with rapid destruction, usually of marked edema and dissolution of the epithelium and a lot of the stroma. You'll see lots of neutrophils and necrosis, and these will rapidly progress to perforation. So this is an ophthalmic emergency. And it can spread posteriorly pretty quickly and lead to sclerokeratitis. And in terms of infections, this is the most frequent cause of contact lens associated microbial keratitis. So people that aren't taking very good care of their lenses or get some sort of inoculation, Pseudomonas is one of the most common bacteria that are, involved in that. And so they invade and replicate within the surface corneal epithelium in animal modes of infection. That's how that occurs. All right, so here's another example of a corneal infection where you have a large ulcer in the middle. And there's another view of it. And so here is a very similar picture where you have a low power view of the cornea, and you see all this inflammation within the stroma and disruption of the epithelium. And so this is definitely an ulceration. And here's Descemet's membrane underneath. And you can see the inflammation that fills the surface of the stroma and dives deep within the stroma. And so looking closely at this, you can kind of start to make out organisms. Here's a little bit of corneal epithelium that's remaining, and then a lot of inflammation within the stroma. And so if you look closely, you can start to see organisms that look like hyphae. And so here's a PAS stain, which does a very good job. So when we do corneas, when you have a penetrating keratoplasty, you have, in terms of your protocol that you order, you have H&E PAS, H&E PAS. That's how we do it here. And so you automatically get this PAS to be able to take a good look at the basement membrane, Descemet's membrane, and to look for organisms. So that's a real advantage in terms of that. I don't know if other places do it differently, but that's how I have been trained, and that's the protocol that we use here. Okay, and so looking on, here's another graft where you see a large ulceration in the middle, and this was actually a perforation of the cornea. And here is the epithelium that is destroyed, and it's really destroyed the entire thickness of the cornea centrally. And so if you look more closely, you see what look like inflammatory cells deep within the stroma, and those look like giant cells. So as we get closer, you see that there are hyphae that you can see that look like they're in there as well. They are. And this is a PAS stain showing you those giant cells with some hyphae off to the right side there. And then the GMS, of course, shows those hyphal forms. And there's also some yeast-looking forms as well. Here's another view. And so this is fungal keratitis, and this happens to be fusarium. The only way to really know what it is, of course, is to culture it. And so I'll often get calls from the OR, do we need to culture this, et cetera. And it's highly recommended that they do to be able to recognize what the organisms are if possible. Okay. So here's another one. So here's a graph where you've lost all the epithelium again. Very similar picture. You see all the inflammation within the stroma. And you see neutrophils within there. And then here's a PAS, and again, you see fungal forms. And there they are. So you see both yeast and hyphal forms, and they're septated. And so there's one of the pieces of art that I've done. So a lot of these are posted on our Instagram social media site for anyone who's interested. I'm the person that posts a lot of these. So, okay. And so this is fusarium as well. So you can see when you look at the overview of this, you'll have the cornea that has absent epithelium, absent Bowman's layer, hypercellular stroma. Usually Descemet's is intact unless you've had a perforation. And then on your PAS stain, which you routinely get, you can see the fungal forms. And of course, GMS highlights that very nicely. And so in terms of fungal keratitis, it's more prevalent in the South. So we see it quite a lot here in Louisville, saw it in Nashville. It's more rare than bacterial. And often these people are the people who are gardeners or working outdoors, not protecting their eyes. So that's often the story that you'll see. And people who, of course, are immunosuppressed are at risk for this as well. Most of it is aspergillus. You can see Candida, and we've seen a lot of fusarium. So usually there's a deep crater with raised edges when you look at the person clinically. And then, of course, with the penetrating keratoplasty, you often see that deep crater or perforation of the cornea. Okay. So then we're going to go on to another interesting infection. So when I teach ophthalmology residents, one thing that works very well is to do a case-based format. So I'm used to talking to people and asking questions and having them answer in terms of what they think the differential is, what the clinical scenario is. And we do this in the setting of their ophthalmology setting where they have their faculty. And so then the faculty can ask all sorts of clinical questions as well. And so the didactic lectures for me working with the ophthalmology residents don't work as well as the case-based format. And so if you're, as a fellow, going to be teaching, that is the method that I would suggest that you use. There's a lot more interaction, and you can find out whether the residents or fellows understand what you're teaching them, whether it's pathology or ophthalmic residents. And it helps a lot in terms of communication. So let's look at this infection. So this is the scraping, which you don't see very often. I got to see this case at Vanderbilt. And if you look closely, there are little organisms within the scraping. So this is just a piece of epithelium that went through the cytology lab that was processed. And if you look closely, you can see little organisms within the epithelial layer. So scraping off the surface of the cornea. And then here they are as well. And here are more of them. And so you don't see this as infrequently as you would think. So often clinically, there's a ring infiltrate. And one thing that really helps, we get the radiographic imaging as neuropathologists, and of course, we're very used to that and having that clinical correlation. But with ophthalmic pathology, often you don't get the clinical photos. And so I work hard to be able to get those when it's really needed. And in terms of teaching, it helps very much. A lot of those photos are within that Eagle Eye text. So if you're trying to teach and need those photos, that book has the availability to use the images with permission online for teaching. So you'll be able to access that and be able to show what clinically one would see. And so here's this ring infiltrate around the outside of the cornea where you see this white ring. And this is often seen in this setting. And so here this is. You can see again that it's an ulcerated cornea and that there are a number of cells within the stroma, so way too cellular. And then if you start looking closely, you can see that there are organisms within the stroma. So this has a classic clinical story. And what it is that people are washing their contacts in water. So don't do that. I've often heard this story traveling abroad. One of the stories that I've heard several times are people traveling to China on business, and they would rinse their contacts in the water, as well as, all across the world. But I've heard that story a couple times. And then, of course, swimming in fresh water with contacts. So here's a Giemsa stain. And you can see that these are really large organisms compared to the fungal organisms that we looked at before. There is an immunohistochemical stain for this. And then here's a nice electron microscopy photo in the reference. Okay, so this is the Canthamoeba keratitis. So what you see is an ulcerated cornea. You see these large organisms that penetrate the stroma. And the story is that this is a contact lens wearer who washed their contacts in fresh water. And so it's a protozoan paratype. It has both a cyst and a tropozoite form. There are two major types that you see, Castellani and polyphagia, are most commonly involved. Again, this rose to prominence with soft contacts lens use. Very, very painful. So they'll come in with a very painful interstitial keratitis. Sometimes it's non-ulcerative, but most of the cases I've seen have been an ulcerative keratitis. And usually when the case comes in, the clinician knows what it is and will write it on the form. Okay, so first described in the 70s, and it dramatically increased in the 80s because that's when soft contact lens wear came out more often. So 80% of people are wearing soft contacts. Of course, it can be water exposure without contact lens use. The frequent replacement soft contacts, if they're not replacing them as frequently as they should. The patients who wear them overnight for orthokeratology, those patients are at risk. And then, of course, swimming in fresh water and tap water cleaning. So the differential here includes herpetic and fungal infections. So, of course, you would stain for all of those organisms. Okay, and here's a nice summary view. I really like when you put everything together, and you'll see that as we go through our presentation, because it really helps people who are newly learn, and also I'm a real visual learner. This is how I like to learn as well, where you put everything in the same place. So here's the ring infiltrate. There are the organisms within the stroma of the cornea. Here's a Giemsa stain. And then here's a very close-up view of one of the protozoan organisms. And then this is calcifluor white, which a lot of us don't have access to, but you can use to stain those. Okay. And then, of course, if you look at the CDC, you can see the Canthamoeba life cycle, these cysts that are in dirt or water that form this trophozoite form. And then they can go through the mucous membranes, the nasal passages, through the eyes as well, or ulcerated skin. Okay. And so here's my little summary view where you see the organisms within the stroma, and then they often create that ulcerative keratitis. Okay. You'll see hyphemas quite often. This is blood staining of the cornea. And so in terms of a clinical view, you'll see that the cornea will be dark and violaceous colored, and seeing that clinically, you would think of blood pretty quickly in a history of trauma. But when you look at the cornea, it's not that impressive on low power. It's kind of a clinical history that you want to have to go looking for, because sometimes it's more subtle than others. And so if you look in the stroma, you see that the epithelium is intact here. There are some subepithelial bullae, meaning there is some edema within the corneal stroma. And we'll talk more about that as we get to bullous keratopathy. And if you look within the stroma, you see the little red particles that are within there. And if you get closer, you can see them here. There's a bullae showing that there's stromal edema, where the epithelium pulls away from the basement membrane because of edema within the stroma, that water barrier has been broken. And then you see these subepithelial vacuoles that are here. This is a really good indicator that these subepithelial bullae are real. So in order to think about bullous keratopathy and think about edema within the cornea, they describe the stroma as like a cotton candy-like look. And I think once you look at it for a while, that becomes a little more evident. But when you see these subepithelial vacuoles, like right here in the middle, these three little dots, that's a really good indicator that there is edema within the stroma, and that the subepithelial bullae are real and are not artifactual from processing. Okay. And another good look in terms of thinking about stromal edema are the hydropic change that you see in the basal cells. So these are now almost the same color as the stroma or Bowman's layer. They're filled with water. The cytoplasm is swollen and they're this pale color. So the subepithelial vacuoles and the basal layer hydropic change are good indicators that the stromal edema that you're seeing is real. And so all these little red dots within here are degenerating red blood cells, these little fragments. And so you have a bullous keratopathy with subepithelial bullae, subepithelial vacuoles, the basal layer hydropic change, and then these degenerating red blood cells within the stroma. And so here they are. And of course, what you can do is a trichrome stain to see those more clearly. And they really pops out with the trichrome. And there's a good look at that. Okay, the iron stain will also pick them up. So that's another good stain to do. So that's hyphema. So what happens is there's high intraocular pressure, which can cause blood staining of the cornea. If the endothelium is damaged, then the normal intraocular pressure can still have blood pushed into the corneal stroma. And then the blood cells break down into those hemoglobin products, which I think you can see very well on the trichrome as well as with the iron stain. Okay, so now we'll talk about bullous keratopathy. So this used to be called pseudophakic bullous keratopathy because you'd have cataract surgery and the endothelium would get damaged, which is your barrier, your physical and active ATPase pump barrier to keep water out of the stroma. And therefore, the stroma would become edematous. You get the subepithelial vacuoles and bullae, and the optical clarity would be gone. So you'd have a cloudy cornea. So here's an example. This is a nice look where you see that it's very even across the whole cornea. The stromal thickness is very similar across the whole button. And you can easily see the bullae from here. And so the question is, are they real? And you get closer and you see that this person has had an injury. And so there is no Bowman's layer in the middle. And you see that the epithelium has regrown and is hypertrophic, where you have more layers than the other areas. Okay. And so that loss of Bowman's layer is highlighted here. So here's the epithelium, and there's the basement membrane layer. And then you see the subepithelial vacuoles as well as the hydropic change of the basal layer. And you see there's no Bowman's layer. So this has been a prior injury for this patient. Here are the subepithelial bullae that are here where the epithelium pulls away. Here's that hydropic change that we talked about before. This is a common case that you'll see is bullous keratopathy. And usually the clinician will write that on their requisition because the patient cannot see through this cornea that either has been damaged because of prior cataract surgery or some sort of trauma. And so what happens is you can have fibrous cells grow between Bowman's layer and the epithelium, and it creates a fibrous pannus. So often if a patient has been transplanted before, you'll see a peripheral fibrous pannus. This can also be a fibrovascular pannus that can grow in. And you can have neovascularization of the corneal stroma where blood vessels proliferate as well. And of course, both of those things destroy the optic clarity of the cornea. And so here's a peripheral edge where you see these surgical changes going through the full thickness. There's some Descemet's membrane that's from the original cornea. So the original cornea is on the left and the transplanted one is on the right. And you can see there's this subepithelial fibrous pannus where it grows in between Bowman's layer and the epithelium. And so there's a PAS, which shows you that little bit of Descemet's membrane and that surgical joint right there between the patient's native cornea and the transplanted cornea. Okay, so bullous keratopathy forms when you have persistent corneal edema, usually to endothelial damage, right? And so it can be either the decreased number of cells getting older, abnormal cell function, or prior surgery where you've had a cataract replacement with a foreign body lens and the cells have been damaged. That's the most common, pseudophakic bullous keratopathy, right? Okay, so a quick slide about calcific band keratopathy. So as we age and in patients that build up additional calcium for physiological reasons, you can see that there is calcium deposition right along the basement membrane of the endothelium and involving Bowman's layer. And so, of course, you can't see through this calcified membrane. And so often these are very shattered specimens when you put them on and try to cut them on the microtome, but it's this heavy calcification in that location, and that's called calcific band keratopathy. And so you'll see that every once in a while for a reason for corneal transplant. Okay, so Fuchs dystrophy. I've got a lot of slides on this one because I just think it's so neat. All right, so Fuchs dystrophy, what happens is that the endothelium produces way too much basement membrane, and the endothelial cells become weak, and it pooches out in between them and creates these little buttons, almost like mushrooms. And so the guttae comes from the German drop, and you see it protrude posteriorly through that area. And of course, what happens is you've damaged the endothelium. And so now it can't form that physical barrier and the cornea becomes cloudy. And so the story with these patients is it's usually bilateral. It's usually as you get older. And in the morning, their vision is worse than later in the day because as their eyes open and some of the air gets to them and dries them out a little bit, the optical clarity gets a little better. So that's a classic clinical story. And these, clinically, when they do their slit lamp exam, this looks like beaten copper, these little anvil-shaped guttae that poke out. And so the clinicians know what this is and will write down Fuchs dystrophy. And so, of course, our PAS highlights this very nicely. So the way that we write these up is that it's thickened. So Descemet's membrane is thickened, and it has those guttate excrescences, and that fits with Fuchs dystrophy. Now, as you get older and you see corneas transplanted from patients who are older, sometimes peripherally you'll see a couple of these, and that is not Fuchs dystrophy. This is where it that beaten copper look is all the way across Descemet's membrane throughout the corneal button. Okay, so one of the neat things that they've developed in terms of surgery is the ability to just remove the inside of the layer of the cake. And so first, this was the DASEC. So Descemet stripping, automated endothelial keratoplasty. What does that mean? Well, they would cut off the inside, a little bit of stroma, Descemet's membrane, and the endothelium. And then the graft they would place would be the same from the corneal graft donor. And so you wouldn't do a penetrating keratoplasty. You would just poke these holes and replace the bottom layer of the cake. So now what they're doing is DMEK, D-M-E-K, where they just do Descemet's membrane and the endothelium, no stroma. And so that's what we're going to look at. Okay, so here they are. So all you get are these tiny little specimens. So in terms of people who are interested in thinking about how do you process these specimens in the lab, what we do is have the PA or technologist put ESN directly in the container, shake it up so it's visible, and then you can either bisect it or not. And often we put these in mesh cassettes because if you put them in paper, it will totally distort the morphology, and it's like looking through stained glass where it's all broken. And so you really do want to have cassettes with very small holes, and you want to use ESN to enable the histotechs to be able to see the specimen. And so then again, we do H&E, PAS, H&E, PAS. And these bake overnight at low temp to be able to stick to the slide. And so if you look at a PAS, we're going to look at probably way too many of these. You can see these guttated excrescences that stud the membrane, and they're all different sizes. And you see how thick the membrane is, and sometimes they're buried within there. And you see that there are very few endothelial cells. So when I sign these out, it'll be thickened membrane, PAS positive with guttae, and rare endothelial cells. And I often give a count. And a lot of colleagues do that as well. How many endothelial cells per high power field? Okay, here's an example of a really thickened one where they're buried. And this is the majority of the cases that I see look more like this one on the left. But sometimes you'll have to look internally for the guttae. And so here's a nice example of that from Dr. Eagle's book, where you see sometimes the guttae are buried within there. Here's another example. And the endothelium, there are less endothelial cells, okay? And so here's a good H&E with the PAS underneath to show you the direct comparison and how thick it is. And then here are these buried guttae that you see that you go look for. All right, so there's an ink on paper that we did as part of our social media postings, and there's another one. So this is kind of the look that I look for. Less endothelial cells, thick membrane guttae. Okay, so 5% of Americans over age 40, so you're going to see this as part of your practice, usually bilateral, usually middle-aged to elderly. More common in women, the inheritance pattern is variable. It's the most common indication for penetrating keratoplasty for a corneal dystrophy. And of course, there's a litany of corneal dystrophies that one can learn about. And I did not include those in this presentation. So this is the most common one of those. And it's a leading cause of bullous keratopathy. So something that you're going to see every day as a part of ophthalmic pathology. And so again, those guttae are anvil shaped, the endothelial cells are sparse, and there's the diffuse corneal edema that you see when you have a penetrating keratoplasty. Okay. All right, keratoconus. This one's neat too. Okay, so there's something called Munson sign. And it looks literally like there's a pyramid that projects from the corneal surface right at the edge of the limbus, where it projects outward and looks like a cone. And this is from the University of Iowa, these photographs. And so when you look at your slide, even if you look at the slide without looking under the microscope, a 1x view of the slide, you can see that it's going to be keratoconus because the edges are very thick, the middle is very thin, and it's very hard to get these on the slide without there being a lot of folds within the specimen itself. And so this type of look, you know it's going to be keratoconus. So let's look a little bit closer. So here's the overarching view where you see the edges have the full stromal thickness that's normal. The stroma in the middle is very thin. And again, there's the other thick edge on the other side. So then here's another artwork of mine where this is kind of the overreaching view of what you see, the thick at the edge, thin and folded in the middle, and stromal thinning. Okay, so looking a little bit closer, you can see how irregular and folded it is in the middle. And so here's the edge where you have this normal look, normal stromal thickness, and everything is nice and laid out. And then as you go towards the center over here on the left, you see how intense the stromal thinning is. It's about half. Okay, so looking in the middle, what happens is there's pressure posteriorly. The stroma is weak, and it pushes the cornea outward. And so whereas Descemet's membrane has that high tensile strength and can take the pressure for the most part, Bowman's layer does not. And so what you look for in the center where the stromal thinning is are these Bowman's layer breaks. And of course, a PAS stain showed you that very, very well. Okay, so here's another one over here where you have this break of Bowman's layer. And here's more with the PAS. So up here on the left, you see a Bowman's layer break. And here you see this also with a fibrous pannus underneath. And then over here on the right, you see another Bowman's layer break. So there's central stromal thinning and Bowman's layer breaks. And so high drops, this is one of the only cases I've seen, and it's a very old case that I took pictures of when I was a fellow. So they're not the best pictures, but what you can see is that there's a full thickness, because this was the full corneal button, break in the cornea. And you see how there's, it's a very pale pink color. And if you look closely, there are breaks in Descemet's membrane. So Descemet's membrane has a high tensile strength, but if this is left unchecked and not transplanted, then eventually it can fail. And what happens is there's immediate clouding of the cornea, immediate pain, and visual, not total loss, but visual clouding where you can't see through the cornea anymore because you've broken your physical barrier to the hydrous solution behind, right? And so the cornea fills with water, the stroma swells, and this can perforate. Okay. All right, so keratoconus is a degenerative disorder. It's non-inflammatory, and you have that bilateral pyramidal corneal ectasia called Munson sign, where it protrudes anteriorly. And so what happens is the central portion of the stroma gets thinner and gets pressed outward. Usually presents after puberty, and it's associated with some systemic disorders. Atopy, Down syndrome, and Marfan syndrome as well are some of them. Okay, so what you look for this is that 1X view, which is pretty easy to see. You have that focal discontinuity of the epithelial basement membrane layer and Bowman's layer with those Bowman's layer breaks, thinning of the central stroma. And then you can also have stromal scarring within there as well. If you break Descemet's membrane, that leads to high drops. And then iron staining. There was a wonderful ophthalmologist at Vanderbilt called Dr. O'Day. And he was such a good teacher. And one of the things he loved to teach about was this iron staining. And so if you think about the shape of that pyramidal shape, and this is called a Fleischer ring because it's iron only, that iron deposition would occur right around the outside of that pyramid. And it's because the tear film would settle there. And so the iron would accumulate there, and that creates that Fleischer ring. So here is where that would accumulate. And here's that Fleischer ring that you can see here on the bottom in E. So there's Munson sign in A, there's a low power view in B, and then C is the central part of the cornea with the stromal thinning, and below are the Bowman's layer breaks. And then here is the iron stain at that peripheral edge that shows you that Fleischer ring. Okay. All right. So desmetocele is our next one. And so this is very clinically important because the cornea can perforate. So what it means, what a true desmetocele is the epithelium sitting directly on the Descemet's membrane. And so you've lost all the stroma. So this occurs from usually trauma or ulceration. And so here's a great example of a desmetocele epithelium directly on Descemet's membrane underneath. Okay, there's a PAS to show you that. And so what's the problem here is that there's an imminent risk of corneal perforation. And so these patients tend to be transplanted right away. And so clinically they'll see this, and it's rare that I get one of these, but that is a true desmetocele. So if there's any stroma in the middle, it's not truly a desmetocele. And so, you know, anything that would cause ulceration, injury, dry eye disorder, trauma, immune-related disorders that can lead to injury and ulceration of the cornea. Okay, now looking at the conjunctiva. So a pterygium is like, the way it's described is an insect wing that grows over the limbus of the cornea. So if you think of an insect wing coming from the nose across, and we're going to see a picture, across over to the limbus of the cornea and inflicting on the visual field of the cornea. And so a pinguecula, which is a relative of that, doesn't go over the limbus, but a pterygium does. And so most of the surgeons send this to you as pterygium. And so you see the conjunctival epithelium here, and you see underneath the substantia propria, and within that is a lot of solar elastosis. So this is usually caused by sun damage, exposure of the eye, and this is a degenerative process. So here's the epithelium, and here's this gray elastotic degeneration, which would highlight very nicely with an elastic stain. And so here's the graphic representation with the art. So here's the solar elastosis, the epithelium, And here's a really dramatic example where you have all the solar elastosis within the substantia propria underneath the epithelium. And sometimes you can have substantia propria scar as well that you will see in association with the pterygium. More solar elastosis, more just very graphic art so you can see the layers you're supposed to look for. And then here's a great look at that wing-like growth where it's often nasal. It can be nasal or lateral. And you can see that it really does look like an insect wing with the veins that go through it and that solar elastosis underneath. Okay. So it's derived from the word for wing. It's a degenerative process with that wedge-shaped growth, and usually from UV or environmental exposure. And it's the solar elastosis and actinic damage that occurs within the substantia propria. All right. So now we're going to talk about ocular surface squamous neoplasia, also called conjunctiva intraepithelial neoplasia of the conjunctiva. So normally the conjunctival epithelium looks very ordered, and I'm sure you all know very well about squamous dysplasia. And you can see that this is a full thickness dysplasia with thickening of the epithelium. So this is a surgical specimen where this is, they used to be graded 1 through 3, but now it's just either CIN or invasive squamous cell. And so this would be CIN or OSSM. And so a Ki67 is a really nice stain to look for proliferation with all the layers of the epithelium. You can also use P53 is a nice companion for Ki67 to look at that full thickness staining, as well as I often use a P40 when I think about invasive squamous cell carcinoma, as well as a P63. And so that's something you can do if you're worried, as well as a PAS stain to look for the basement membrane. But often these are very surface specimens, and they'll treat with chemotherapy after. All right, so here's a nice example where you see normal conjunctival epithelium, and it just immediately transitions over here into the dysplasia. And so here's a nice example too, where you see the normal epithelium immediately transitioning into the dysplasia. All right, there it is again. And here's a nice example where it's full thickness dysplasia. And there's the Ki67. Okay, so usually middle-aged males, slow growing, they surgically excise them and treat with chemotherapy if needed. The one thing that's very important to remember, and this can be a presenting disease for HIV. And so if you have someone younger than usually about 40, it's been documented in the literature, particularly in Equatorial Africa, these patients are at risk of this being a presenting symptom of HIV or HIV infection. And so, of course, UV exposure, ionizing radiation, high-risk HPV, immunosuppression, injury, and vitamin A deficiency, all those are risk factors for CIN. But if you have someone who's younger, you really do want to talk to your clinician about this. This patient might need to be tested for HIV. All right, this is a fun one. I presented this one at our last meeting as a poster, if anyone came by and saw it. So they thought this was a pyogenic granuloma. You can see here's the eye and this projecting red vascular bump. And this patient just came in and this was a new growth. He was 62. And so immediately when we saw this on the slide, we knew that this was not a pyogenic granuloma. You see all these giant organisms in this ulcerative surface, a lot of inflammation, and here they are. And here they are bursting and sending out organisms. Here's a very primitive form, the trophic form of the organism. And I'd never seen this before. It was easy to look up, and I showed it to some of the more experienced pathologists in the practice, and of course they knew immediately what it was, and we're like, yeah, that's what it is. So here they are again. Here's a GMS and a mucocarmine to show you these encysted organisms. There's a Giemsa stain, and then here's the artwork. And so looking back in the literature, I was happy to see that other people were drawing things too. And so this is rhinosporidiosis. So these are giant organisms. And let's look at the word slides to discuss a little bit about it. And so it's an emerging infectious disease. It's in the class Mesomycetosea. So it includes both animals and fungi. What happens is that the epithelium is damaged in either contaminated water or inhalation of spores from field dust are the proposed mechanisms of infection. So cases in tropical, subtropical regions are most common. And again, this is an emerging infectious disease, so you might see a little bit more. And it really looks like a chronic granulomatous reaction in a vascularized mass. And so most of them are sinonasal. They can be eye as well. They can be throughout the body. Disseminated skin is a rare presentation, and it's endemic in South Asia and tropical areas. So you need to do a tissue biopsy and then surgical resection, but you want to make sure if the patient has this that you advise the clinician to look at all the mucous membranes. And this patient, unfortunately, was lost to follow-up. This is Rhinosporidium cerebri, and you got to consider it in pyogenic granuloma with that exposure sort of history. And again, you completely surgical excise and follow them to look for additional lesions. Okay, there's the references. And so thinking about pigmented conjunctival lesions, this is going to be a very brief overview of these. So here's a temporal conjunctival lesion in a young patient. I'm going to show a lot of pictures of this because it's a common thing that you see. And so this has been there for a long time for this patient, okay? And so here are the photos. And you see kind of this vascularized tan mass off, a little bit off the limbus on the conjunctiva next to the cornea, okay? And so when you look at these, they're very, very busy. And so you can see that there's thickened epithelium with a lot of cellularity. And when you look very closely, you see there are these cyst-like spaces within the conjunctiva, and again, a high level of cellularity. And we're going to flip through these pretty quickly. So it has this nested architecture. You can see that very well here. And this is the conjunctival nevus. So they're usually present at birth, so you'll get that history. They have these cystic spaces. They can be compound or subepithelial. Most are brown, sometimes they're red, and often they present with hormonal changes, so puberty, pregnancy, and they're benign. They're hamartomas. They're made of course, modified melanocytes, and again, puberty and pregnancy are when you see this. And in children, this is the most common conjunctival tumor you're going to see. Very, very few lead to melanoma. And it's the same classification as other nevi, junctional, compound, subepithelial. So we're just going to look at a bunch of them. So here's one that has pigmentation, that has that very nested architecture. Again, you see these cyst-like conjunctival spaces in there. FOX10 really lights it up and is very nice to view these lesions. There's a piece of the artwork. And then here's a very, very busy one, compound nevus. There we go with the cystic spaces. Go again. And there's a very nice overview one with large cystic spaces, chronic inflammation, and then the nested, if you look closer, architecture with the nevoid cells. There we go. And there's another SOX10. Okay. All right, we're going to keep going. So now we have a pigmented lesion in someone who is mid-age, and she's had it since birth, okay? And then the history is it's grown over the past 5 to 6 weeks. So here this is. You see large area of pigmentation all around the limbus, some within the conjunctiva that's palpebral of the eyelids. And so here it is. And if you look from far away, you see it's like a magic marker line all along the basal layer of the epithelium. There it is. There it is. There it is. So very benign. So this is pigment-associated melanosis or skin tone-associated melanosis. It has lots of different names. More common in patients that have heavier pigmentation than others, usually bilateral, denser at the junction between the peripheral cornea and the limbus. Okay, so usually dense in this area and has that very bland look. There can be some pigment incontinence where it's present within the epithelium. Okay. Here's a patient who is in mid-age and she has new pigmentation. It's growing, it's flat and mobile, but you see that there's a lot more pigmentation here. And so that's primary acquired melanosis. And here's a nice overview where you can see the benign melanosis that you see that's acquired, and then progressing into primary acquired melanosis, and then eventually invasive melanoma. Okay. And so primary acquired melanosis is a precursor. Most cases arise in primary acquired melanosis leading to melanoma. And often those have atypia. So there's primary acquired melanosis benign without atypia, and those with atypia, those are the cases that progress to malignant melanoma. Usually it's unilateral, patchy, and new for someone who's older. And in terms of recurrence, it's how much pigmentation there is in clock hours. Okay. And so Pam
Highfield?
without atypia.
Sorry to interrupt, Dr. Highfield. I just wanted to give you your timing reminder that you requested. We have about 10 minutes left.
Okay, great. I'm going to try to
Thank
get through what
you.
I've got. We'll see. Thank you. Okay, so then there's Pam without atypia, which is benign, with mild atypia, which has that lentiginous pattern, and then severe atypia leading to invasive melanoma. And so I'm going to go through this one really fast because I want to get to the end if I can, okay? So this person came in with pigmentation, and this is a very dramatic case, okay? So lots of pigmentation. You can see that it's raised. There are these called kissing lesions where it also is along the eyelid, and you can see how malignant that looks. And so this patient ended up having malignant melanoma, and all of this was melanoma, and came in very late with this presentation. Okay, so there it is. You can see that it's invasive down into the substantia propria. And I'm going to flip through these very fast, okay? So there is a close-up view. You can see how dysplastic this is. And then this was all over the different areas of the eye, the palpebral area. And then on MRI, they were able to see that there's a mass within the sinonasal cavity. This patient progressed, and it was within the nasal sinus and died 6 months later. So rare, 5% of ocular melanomas are conjunctival, usually better than uveal melanosis, but the mortality is about 25%. Most arise from Pam with atypia, and these go to regional lymph nodes. So, and people usually don't present with something this, like our patient did with that dramatic, but that is an example of invasive melanoma. Okay, so thinking about, I'm gonna skip this slide, conjunctival nevi, the flat pigmented patches that are complexly associated are the early stages of Pam, Pam with atypia, and progressing to malignant melanoma. All right, so eyelid. So we're gonna go fast through these. Of course, eyelid includes everything that's there, all the adnexal structures, melanocytic lesions, and so I have a group of cystic type lesions that kind of compare and contrast. So that's what we're going to look at. Thinking about a patient where it's a cystic eyelid mass that they send to you. So hydrocystoma is a benign cystic lesion that looks like this. It can be eccrine and apocrine with that decapitation secretion. And so often these are fluid filled. The eccrine ones they'll describe as a bluish lesion. So there's our artwork, and here's our summary slide. So there's a hydrocystoma, this benign cystic lesion of the eyelid. And so they're usually Mall's gland cysts or cysts of the sweat duct. They can be eccrine or apocrine with that decapitation secretion. Often I don't differentiate between the two. They have a low cuboidal epithelium and are very benign looking. So you'll see those quite often, okay? And then of course, epidermal inclusion cysts. I have way too many slides for this because it takes a good picture, but you'll see this very, very often. So I'm literally gonna flip through these. Here we go. Because everyone knows these. Often they'll have a granulomatous reaction next to them when they burst. And so there that is with the keratin inside. If you get a cyst in terms, there's the keratin of your differential and you haven't found one yet, then keep cutting deeper because that's another thing with that communication. You'll often run into a cyst that is not present on the surface. Okay. So now thinking about this, there are infectious processes and everyone, this is like the immediate recognition that everyone does in pathology. This is molluscum, and you see this cratered lesion with these bodies coming out the surface. Here they are, a really good example. And so those are Henderson-Patterson corpuscles. So that's caused by a pox virus, often water exposure. And you see that crater-form look with those corpuscles being extruded from the surface. Another kind of cystic lesion. Then we have basal cell carcinoma, which everyone knows well. Has this basaloid architecture that connects with the surface, often cystic spaces, calcification, and it has this picket fence palisading along the side, which often pulls away and creates that artifactual separation between the stroma and the cells. You can see that here in the artwork. And then this is the most common malignant tumor of periocular skin, not squamous cell, but basal cell. So you'll see a lot of these. There's another representation. So then chalazion. So these will come as chalazion, and you'll get this soft tissue with all this granulomatous reaction. What you're looking for are these artifactual vacuolar spaces where the fat has been dissolved. And so this is this glandular lipid-like material that has this granulomatous reaction around it. I often polarize these to just make sure that there's nothing on the slides that's a foreign body. I don't usually do infectious stains on these with that clinical information that this is a chalazion. And of course, the thing you need to worry about, here's that granulomatous reaction, is a sebaceous tumor. And they can have necrotizing granulomas. So if you see this, you may want to do special stains, but recurrent chalazion, probably not. Lots of necrotizing areas. And they're these lipid vacuoles that you look for. Okay, there they are. And sometimes you don't see that. I do a lot of recuts to be able to find it in the giant cells. So there's that graphic representation, and there's chalazion. So what you worry about is sebaceous lesions. So these are chronic lipogranulomas, the chalazions are. And so you want to rule out a sebaceous carcinoma. So quickly looking at those, here's sebaceous hyperplasia, which you can see, a sebaceous adenoma, which has a more basaloid organoid look to it. And then sebaceous carcinoma is what you want to rule out. And so these have a lot less of the pale vacuolization. Often they're described as yellow type lesions. And you see the vacuolization and the mitoses when you look on high power. Okay. And you can do an androgen receptor stain for those as well. And so last case, here's a patient with a violaceous lesion. This one's kind of fun. They thought it was going to be a hydrocystoma. You see that it has this kind of nested look to it where it has these central spaces, almost like cysts. And these are filled with mucinous type material. And when you go to stain this to figure out what it is, it's CK7 positive. It has some synaptophysin immunoreactivity. Then it's ERPR positive. It has that mucin-like alcium blue and mucocarmine positive material within those vacuolar spaces. And here's the art representation showing you that cystic look. And so this is endocrine mucin producing sweat gland carcinoma. And so the thing you need to worry about here is it can have an invasive mucinous component. It's the eyelid of older females. We already went through the differential, but the thing that you need to rule out is metastatic breast. So these patients need to be followed carefully. There's our summary slide. And you need to look for systemically a breast carcinoma. And solid pseudopapillary carcinoma has the most similar staining pattern and look as the endocrine mucin producing sweat gland carcinoma. All right. That is our summary slide. And then you all can look over this for more information on that one. And I include a lot of references on that. Okay, so resources. So I'm part of the Atlas committee. And so if you go to the Pathology Atlas for the AAO and hit log in to access, we have an area where you can create an account and access the online digital slides that are annotated for the Pathology Atlas. It's a great place to learn and to study. These are the books I recommend, and so that will be a part of the presentation. And then look at us on social media, both the AANP site as well as our iPathology for the Atlas. And then that's it. And if there are any questions.
See any questions in the chat? We could
Okay.
take a question or two. We'll give it just a few moments to see if any questions come in.
Okay.
Somebody said nice drawings. Oh, there is a question in the chat now. Besides AR, do you recommend any other IHC for sebaceous CA?
That's the one that I
Cancer.
use. So there's you know, everybody wants to do an oil redo, but you have to do that at the time of frozen section, right? So there's nothing else that I really recommend for that.
Well, I don't think I'm seeing any other questions come in, so thank you again for joining today's AANP Teaching Rounds presentation. We would ask that you take a few minutes to complete a short evaluation. Completion helps ensure accurate reporting to the accreditation board. A link to the evaluation will appear on your PathLMS screen upon the conclusion of the Zoom meeting, or you can navigate back to the main course and select the evaluation option. Once you've completed the evaluation and selected your credit amount, please then select the appropriate certificate based on your credentials. The PowerPoint slides and recording will be posted to the AANP website in the next week. Thank you again to Dr. Highfield for an excellent presentation. This concludes the session for today.
Thank you all for coming.